Hello,
Or will
Assalamu alaikum. Hello, and Assalamu alaikum, everyone. Um, my name is Dr. Jahazeb Kamal, and I'm Director of Medical Affairs for Getz Pharma. Thank you very much, everyone, for joining us today. And today's topic is how we can preserve the antibiotic use in the clinical, on overall clinical use. And the agenda for today's meeting is we will going to increase the understanding of the rational use of antibiotics and obviously all the participants can ask some questions that we from the experts. Also during this process, we will learn how we can preserve the use of antibiotics in clinical use. For this, we have a great panel of experts with us, and also we have a great speaker. We are very, very happy to announce that in this webinar, we have a collaboration with Pakistan Society for Otolaryngology. We have a collaboration with Pakistan Society of Internal Medicine and Pakistan Society of Study for Liver Disease. First, I will introduce Professor Javed Akram. It doesn't require any introduction for everyone, but he is currently Vice Chancellor for University of Health Sciences Lahore and also President for Pakistan Society for Internal Medicine. A great teacher, a great researcher, also a medical advisor to Royal College of Physicians. Professor Tariq Rafi obviously does not require any introduction, but I would like to introduce few things. He's been a past president for the Society of ENT, an ex-president for SARC ENT Society, dean of ENT College, and currently vice chancellor of Jinnah Sindh Medical University, Karachi. A great teacher, great learner, great researcher. Thank you very much, panel of experts, for joining us. We have also a representative from um, Pediatric Association, and Dr. Khalid Shafiq is here with us. He is a General Secretary for Pakistan Pediatric Association. He has been serving the community more than 25 years as a pediatric consultant. And I'm grateful for the president of Pakistan Society for Study of Liver Disease, Professor Brigadier Masood Siddi, to join us. He's a eminent gastroenterologist, hepatologist, and he has years of experience with us. Thank you very much, all the panel of experts
I'm
for joining us today.
I'm I'm past president.
You're past president, sir. Right, sir. Thank you very much, sir. Now, we'll start off this session with the introduction for Professor Ross J. Davidson. He's a clinical microbiologist and professor of medicine pathology microbiology. He's here in Canada. I'm very, very grateful for Professor Ross Davidson to join us. It's 5 p.m. a.m. in Canada at this time. Weather is pretty nice. It's not winters yet, but he is also fellowship in. He has done his fellowship in medical microbiology from University of Toronto, and he is a board certified. He's a consultant anti-microbial stewardship committee, many research publications, more than 200, and an author of books and chapters. He has been associated as a member editorial board for very many eminent journals and several journals, for example, JAMA, NAGM, and antimicrobial agent and chemotherapy. Now, I'll invite Professor Ross Davidson to take share his presentation, and the session is now with him. And all the audience can give us their questions, which will be addressed at the end of the session. You can use the chat box for this. Professor Ross Davidson, the floor is yours.
Thank you very much, and salam alaikum, everybody. Just give me a moment, and I will attempt to share my screen with you. it takes a minute for it to click in. Share screen. There we go. Share. Okay. Slideshow. Okay. Everybody can see, I assume? Okay, good. Well, again,
Yes,
good morning from Canada.
Yes, please continue.
Good afternoon in Pakistan. It's a great pleasure to be here and to share some of my some which is a passion for me, which is antibiotic resistance. I've been to Pakistan several times and truly wish I could be with you again today. But as you are, of course, aware, we have the globe has got a bit of a virus problem, and so we can't travel. But hopefully, when that disappears, I will have a chance to visit your beautiful country once again. In any event, so let's talk about antibiotics this morning, and we're really going to talk about the macrolides, and we're going to focus on the macrolides and use those as an example of how we need to use antibiotics. Okay? So I think, you know, it's very obvious that as human beings, our life expectancy has dramatically increased over the last century, and there are really three primary reasons for that. The first is, of course, sanitation or increased sanitation. So we have much better infrastructure around that. The second, and probably one of the more important reasons, is vaccines, right? We've got a number of vaccines against a number of diseases. And of course, vaccines are in the news today as we hope to come up with a new vaccine against the SARS-CoV-2. And lastly, of course, is antibiotics. And those of us that have practiced medicine inside the last 50 years have been exceedingly fortunate that we've had access to lots and lots of antibiotics. The problem is that trend of new antibiotics is slowly disappearing. We're just not seeing new innovation anymore, right? And as a result, we as healthcare advocates absolutely must recognize the impact of antimicrobial resistance, not only on our patients today, but on our future patients. And I think it really boils down to this, that far too often we simply have not given antibiotics the respect they deserve, in that we've treated them as drugs of convenience. They're a way to you know, placate our patients and move them along. And I think we need to stop doing that. We need to start treating antibiotics with the same respect that we treat any other therapeutic class of drugs that we might potentially prescribe to our patients. So I think if we start doing that, that will go a long way to helping preserve these molecules for future individuals. Right? There's no question there's a changing landscape, and that is we're seeing an increase in antibiotic resistance globally. It doesn't matter which country you live in, but we're also seeing a dearth in new drug development. So that's a powerful combination. We need to recognize that, right? One of the problems is that it's how we evaluate antibiotics, and we recognize that clinical trials are exceedingly important. They let us know that the drug works, and they also let us know that it's safe. But one of the problems with clinical trials is that they don't tend to differentiate between antibiotics. And as a result, we've now had to look beyond clinical trial data. And in fact, even the CLSI and UCAST, which are two societies that determine the resistance breakpoints for antibiotics, have now recognized that. And we're going back into the lab to look at other factors, not just clinical trial data, but the pharmacokinetic and the pharmacodynamic properties of these antibiotics to try and decide, you know, which is the best antibiotic for any given disease that we might want to treat. So let's talk about the macrolides. So these molecules astoundingly have been used in clinical practice for almost 70 years, and they're well supported by clinical trials. So the fact that we've been using them for 70 years says two things immediately. That number one, they're obviously very effective, or we wouldn't be using them, and they're actually pretty safe. or again, we wouldn't have been relying on these molecules for over 70 years, right? In the case of the second generation macrolides, such as clarithromycin, they have the ideal spectrum for treating respiratory tract infections. They typically have activity against Streptococcus pneumonia and Haemophilus and the atypical pathogens like Legionella, Chlamydia, and Mycoplasma. What's really interesting about these molecules, though, is certainly in the last decade or 2 decades, we've recognized that they have properties that go well beyond that of being an antibiotic, in that they have anti-inflammatory and immunomodulatory properties. And what's really interesting and unique about these molecules is that you can't reproduce the anti-inflammatory properties with steroids alone. So they have some very unique features, and we can discuss those a little bit later. So erythromycin was the first molecule that we introduced into clinical practice. And most people today probably wouldn't use erythromycin. You're looking at your second generation molecules such as clarithromycin or azithromycin. Right? The other interesting facet about these molecules is that there's been a number of studies done over the years, some very recently, which have shown quite conclusively that patients tend to do better if they're on a regimen that includes a macrolide. Even those very, very sick patients admitted to the intensive care unit, mortality tends to be better in patients that have got a macrolide as part of their regimen. And that may be due in part to their atypical coverage, but it's also probably their anti-inflammatory and their immunomodulatory properties probably play a very big role in that. So I do want to take a minute just to dispel some of the information that has been floating around the world. As everybody is obviously aware, we have a SARS-CoV-2 or COVID-19 global pandemic. And everybody has been frantically looking for the best ways to support and treat and manage our patients that ultimately end up in the hospital. And of course, we're looking for a vaccine. There was an initial report that came out of France that suggested there was a potential benefit of using hydroxychloroquine plus or minus azithromycin. There was a second report that followed that actually came out of the United States. We need to recognize, however, that these initial reports were observational and or retrospective studies. They were not randomized. There was no placebo control. And interestingly enough, most of those patients actually received steroids, which we happen to know is beneficial in patients who are extremely sick with COVID-19, right? As a result, there has now been very recently several large multi-center randomized placebo-controlled trials that have now been published. And in fact, one meta-analysis that looks at 24 different studies. They've looked at both the potential benefits of hydroxychloroquine and or azithromycin for both the treatment and or prophylaxis of patients against SARS-CoV-2, and absolutely no benefit has been seen from these trials from either hydroxychloroquine, for azithromycin, or for a hydroxychloroquine azithromycin combination. Right? So I did want to take that moment here and share that with you. I know many of you, based on what's happening, are so exceedingly busy in your clinical practice that sometimes I think now we just don't have time to sometimes delve into the literature and take a look at it. But that's the crux of it right now, that despite what the esteemed president from the United States says, hydroxychloroquine and azithromycin should not be used to treat patients with COVID-19. So we have two second-generation macrolides, azithromycin and clarithromycin. They are both very good molecules in their own right, and they both have some uses that you need to be aware of. There's no question that azithromycin is the absolute macrolide of choice when it comes to treating Chlamydia trachomatis sexually transmitted infections, right? Clarithromycin has no role here. This should be reserved for azithromycin. And not so much from my part of the world, but from your part of the world, where I know many of you have to deal with typhoid fever or Salmonella typhi. And this is an organism, a gram-negative organism, that has developed a number of, or has developed resistance to a number of molecules that you might treat your patients with. Fortunately, many of these strains remain susceptible to azithromycin, right? And as a result, it's one of the very few oral options that you have available for treating Salmonella typhi. And so when we take a look at how we use these molecules, right, azithromycin absolutely is used to treat STIs, and it should be reserved for treating Salmonella typhi because it's such an important disease. When you look at the respiratory tract infections, clarithromycin has many advantages over azithromycin, and we're going to talk about that. And the other, of course, area where we might use clarithromycin is the management of patients with H. pylori. So these are both good molecules, but they really do have some niche uses. In Canada, we use azithromycin as our parenteral macrolide. We don't have access to parenteral clarithromycin, and we would rather use the parenteral form of azithromycin than using parenteral erythromycin because of the infusion-related adverse events associated with it, right? So we're going to focus really on the respiratory tract infections, but I think it is important to recognize that azithromycin does have some very important roles that clarithromycin does not, and that is treating STIs and as an excellent oral option for the management of patients with typhoid fever, right? So again, we know from clinical trial data, if you take a look at clarithromycin versus azithromycin in a clinical trial, both of these drugs will probably look equivalent. But we know there are some differences between them. So if we step back for a minute and we go back into the lab and we take a look at their in vitro activity, there's no question that when you first look at this table, you really don't see many differences between clarithromycin and azithromycin. They more or less look identical. Azithromycin may look a little bit more potent against Haemophilus influenza in the laboratory setting. In the clinical world, that's not really true, and we'll explain why in a minute. But what's important to note here is that you cannot look at the in vitro activity by itself. You need to go well beyond just the in vitro activity. You need to start looking at other pharmacodynamic and pharmacokinetic parameters. So let's look at some of the pharmacokinetics. If you take a look at the drug levels that you can achieve with clarithromycin, if you look in plasma or serum first, you find that the levels of clarithromycin are somewhere between 2.1 and 2.5. And that's very relevant to us because the mean MIC for the types of organisms that you might find in plasma or blood, like pneumococcus, are typically much, much lower than the levels that you can achieve. So for those patients who might go bacteremic because of their pneumococcal pneumonia, clarithromycin tends to hit levels in the serum high enough to manage those patients, right? But of course, most of us are treating pneumonia or bronchitis or something like that. And so we want to know what kind of levels you can achieve in the epithelial lining fluid or the lung, and or the alveolar macrophages, where we worry about the atypical pathogens like Legionella, Mycoplasma, or Chlamydia. And you'll notice that clarithromycin hits exceedingly high levels in epithelial lining fluid. In this study, about 34, in many other studies as high as 40. And that's relevant to us because if you take a look at the MICs of the type of pathogens we're trying to treat, they're much, much lower than that. And in fact, if you take a look at something like Haemophilus, which has a relatively high MIC against clarithromycin, it's somewhere between 2 and 8. You're still 5 to 10 times higher than the MIC in lung fluid. If you look at alveolar macrophage, you find that both azithromycin and clarithromycin hit exceedingly high levels. And again, so they're very good molecules for treating the atypical pathogens. So those patients with mycoplasma or chlamydia or even Legionella. But we know half-life is relatively important. And this is the one area where, at least in respiratory tract infections, where I think clarithromycin has the edge, because it has a relatively standard half-life as far as antibiotics go. It's typically it's about 5 hours, whereas azithromycin has an exceedingly long half-life of 68 hours. And we recognize now for some populations of patients, particularly the pediatric population, where they may be in daycares and closely associated with each other, that having that lower half-life allows the drug to be eliminated from the body much faster. Having an extraordinarily long half-life means that you've got subtherapeutic levels of antibiotic in both your tissue and your serum for perhaps almost a week. And when you have subtherapeutic levels in tissue and serum, that increases the risk that you may select for resistance. So from this perspective, at least for managing respiratory tract infections, clarithromycin appears to have the edge. And that was really first described back in the late 90s by a fellow named Dr. Guggenbichler. And he examined a very large cohort of children that had received a number of different macrolides, including clarithromycin, azithromycin, erythromycin, and two other ones actually, roxithromycin and josithromycin. And what he found was, irrespective of the macrolide that was used, about a week after they were treated, you could isolate macrolide-resistant Streptococcus pyogenes from their oral pharynx. But interestingly enough, when you went somewhere between 4 to 6 weeks later, only 17% of those children harbored resistant pathogens, at least those children that were treated with clarithromycin, whereas 85% of them still had residual resistant pathogens in their oral pharynx when treated with azithromycin. And that really went down to the probability of azithromycin's exceedingly long half-life. Right? Again, we're delving back into some pharmacodynamic parameters that we don't normally use to try and differentiate between these molecules. And this is a very novel pharmacodynamic parameter. It's called the mutant prevention concentration. It is not something that the majority of labs are ever going to do, nor will they ever report to you. But it's useful for us to try and differentiate between molecules. Essentially, what the mutant prevention concentration describes is the level of drug which needs to be achieved in order to prevent the emergence of resistance. And if you take a look at clarithromycin, it has an MPC 90 of only 0.5. And if you remember the type of levels that you achieve in the body, clarithromycin hits levels well above 0.5 in the serum, in the lung, and in the alveolar macrophage. So suggesting that because of this parameter, clarithromycin is very less likely to select for the emergence of resistance, at least against Streptococcus pneumoniae. Okay? And there are some other studies that have looked at the epidemiology of the macrolides. This is a study that came out of Toronto, and they looked at the management of patients with invasive multi-drug resistant Streptococcus pneumonia. And what they found was that if you had not given your patient any antibiotic previously, at least inside 3 months, they still had a relative risk of about 5 to 7% of being infected with a resistant strain of pneumococcus. If they had been treated twice inside 3 months, the risk more than doubled. But if they saw azithromycin, the risk went to 53%. So the main message from this study was to take good antibiotic histories from your patients, right? And if possible, try not to repeat the same class of antibiotic twice inside 3 months, because this study quite clearly shows that if you prescribe a macrolide twice inside 3 months, you significantly increase the chances of being infected with a macrolide resistant strain. Now, I should point out that this study went well beyond the macrolides and looked at other antibiotics as well. And there is identical data for other classes of antibiotics, including the fluoroquinolones. So if you prescribe a fluoroquinolone to your patient twice inside 3 months, the risk dramatically increases as well. And what's interesting about this study is that when they delved deeper into the data, they found that the most important parameter was receiving the antibiotic, not for the disease in which was being treated. So in other words, if you had a young female who was being treated for a urinary tract infection and was prescribed ciprofloxacin, and 2 months later was sick enough to be admitted to the hospital with pneumonia, that person should not receive a fluoroquinolone. They had one 2 months ago. And there's many clinical guidelines out there now that use this 3-month rule of trying not to repeat the same class of antibiotic. So we'll move on to another pharmacodynamic parameter. And this is a pharmacodynamic model done by one of my colleagues. And the first question they asked was, how well does clarithromycin and azithromycin eradicate macrolide-susceptible Streptococcus pneumoniae? And you can see from this graph, the top line is the growth control in the absence of antibiotic, and it grows quite nicely. If you introduce either azithromycin or clarithromycin into this model, both of these molecules eradicate susceptible strains of Streptococcus pneumoniae. And that's obviously the result that we're looking for in our patients. But we recognize, of course, that we have some macrolide-resistant organisms in our community. So what happens if you introduce a macrolide-resistant strain into this model, right? So again, we see the growth control, right, in the absence of antibiotic. If you add clarithromycin into this model, it still manages to eradicate many of the resistant pneumococcus, whereas azithromycin does not eradicate them to the same degree. So we need to take the experiment a little bit further. The way to interpret this graph is to look at the center line, okay? And any bar that is below the center line will equate to bacterial eradication. Anything above the center line equates to bacterial regrowth. So in this case, we've taken clarithromycin and we've added it into the model against pathogens with increasing resistance to clarithromycin. And you can see with the wild type or the susceptible strain, the one that has an MIC of 0.03, clarithromycin fully eradicates that bacterial pathogen. And it still eradicates pathogens with an MIC as high as 8. And that's relevant to us because many macrolide-resistant pathogens have an MIC between 2 and 8. So not only will clarithromycin eradicate susceptible pathogens, it's going to eradicate some of those resistant pathogens as well. Once the organism is highly resistant, in the case on the right-hand side of the graph with an MIC of 64, it's not going to be eradicated anymore. If you do the same experiment with azithromycin, this is what you find. That if you introduce a wild type or susceptible strain, it will be fully eradicated. Okay? Once the organism has an MIC of 2, the azithromycin is not as capable of eradicating the strains, and that's where we worry about managing some patients with resistant strains or perhaps selecting for resistant strains. Let's go into an animal model and show you the same type of data. So this is a neutropenic mouse challenge model that was done by Dr. Gary Dorn in the US. And what he did was challenge mice with either susceptible strains of Streptococcus pneumoniae or resistant strains of Streptococcus pneumoniae, and then treated them with either high dose or low dose clarithromycin or azithromycin. For those mice challenged with a susceptible strain and then treated with either low dose clarithromycin or azithromycin, about 80% of those mice survived. when they were treated with high-dose macrolides, 100% of the mice survived when treated with clarithromycin. However, when we went to the resistant pneumococcus, again, about 80% survived with clarithromycin at low dose, and 100% survived with clarithromycin at high dose. So the animal modeling data really does back up some of the in vitro laboratory data that we've just been talking about. So let's move on to sort of a real world situation. So a number of years ago, we were looking at antibiotic resistance across Canada. We looked at the macrolides, we looked at the fluoroquinolones, and a whole host of other antibiotics. But this was the macrolide data. And in 1995, we had very little macrolide resistance in Canada. And you can see in the bottom, these are all the different provinces in Canada. And irrespective of which province you went to, we had very little macrolide resistance. It was around 5%. But when we went back and looked almost a decade later, we had huge regional differences in macrolide resistance, right? And what was interesting was that in British Columbia and in Newfoundland, macrolide resistance had not significantly increased inside a decade. When we went to what we call the prairie provinces, macrolide resistance was now somewhere between 10 and 15%, or 10 and 12%. And when we went to the maritime provinces, macrolide resistance was 20% or greater. So the question became, why were there huge regional differences in macrolide resistance in Canada, right? And we, of course, immediately thought that perhaps areas like the Maritimes were using a lot more macrolides than anybody else. In fact, that turned out not to be true. When we accounted for differences in population, there was no significant difference in macrolide use in any one region of the country. So it had to be something else. So if it wasn't total macrolide use, perhaps it was choice of macrolide. And if you remember from the modeling data, we suggested that, at least for pneumococcus, clarithromycin is really the most potent macrolide. So what were people using in the country? Well, if you went to British Columbia, only 14% of all the macrolides prescribed in that province were azithromycin, right? The rest was all clarithromycin. When you went to Newfoundland, only 17% of the macrolides prescribed there were azithromycin, the rest was clarithromycin. When you came to the prairie provinces, between 25 and 30% of all the macrolides prescribed were azithromycin. And when you came to the maritime region, more than 50% of all the macrolides prescribed for respiratory tract disease was azithromycin. And when you do the correlation analysis, it really did fall out quite nicely. For those provinces that were using clarithromycin primarily as their macrolide to treat respiratory tract infections, they had very low rates of resistance. Those provinces that were primarily using azithromycin as their primary macrolide to treat respiratory tract infections had much higher rates of resistance. And in fact, that was borne out a bit later when British Columbia started using more azithromycin to treat respiratory tract disease. 3 or 4 years later, their resistance went up to almost 15%. They weren't using any more macrolides than they used to. They simply changed the ratio. And so because of these sort of studies, we sort of stepped back and said, we know that these are both good molecules, but perhaps we need to use them for the right indications. But I did want to bring this up very quickly, and I'm not going to spend a lot of time on this, but I think it is important, particularly for the clinicians in the audience that are managing patients with very chronic inflammatory infectious diseases like panbronchiolitis, patients with advanced COPD, and bronchiectasis and cystic fibrosis in patients like that. There was a disease that is primarily seen in Asia. In fact, it's primarily seen in Japan. It's called diffuse panbronchiolitis. It's not a disease that we typically see elsewhere in the world. The interesting part about this disease is it had a very high mortality rate, an exceedingly high mortality rate. And most of these patients are infected with Pseudomonas. Now, we all know that the macrolides have absolutely no activity against Pseudomonas. And yet, when I think perhaps out of desperation, clinicians, or there was a group of clinicians, started prescribing the macrolides for those patients with diffuse panbronchiolitis. What they found was that they decreased the mortality rate of this disease. And in fact, the 5-year survival rate in 1984 for patients with diffuse panbronchiolitis was only 26%. After we started introducing macrolides into the regimen, that 10-year survival rate went to 94%. And that is astounding when you think that macrolides have no activity against Pseudomonas. What it means is that the macrolide, or the patients are benefiting from the macrolide because of some anti-inflammatory or immunomodulatory effect. And it's for this reason that we think that if you use a macrolide in patients, say, admitted to the intensive care unit, that they do better. Their mortality is lower. And it's probably because of this anti-inflammatory or immunomodulatory effect. But as a result of many of these studies, my particular university put out what was called an academic detailing service. We were asked, the infectious disease group, the microbiologists were asked to get together and develop a document for family physicians in the community to manage relatively common community-acquired infections, such as urinary tract infections, respiratory tract infections, skin and soft tissue infections. And when it came to respiratory tract infections, the group of panel experts, or the consensus among the experts, was that azithromycin probably should not be the drug of choice for managing respiratory tract infections. It should be clarithromycin. We wanted to use azithromycin for other reasons. And in Canada, we would primarily use azithromycin to treat sexually transmitted infections. And we actually would use it to treat respiratory tract infections for those patients admitted to the hospital that require a parenteral macrolide, right? We would prefer to use azithromycin over erythromycin. In Pakistan, I think that you've got an additional issue, which of course is Salmonella typhi, and azithromycin remains an excellent oral option for the management of those patients. So in conclusion, there's no question that macrolides have an exceedingly long history of clinical use. We know they work, and we know they're safe, right? And interestingly enough, they've been repeatedly shown, even in very recent trials, to reduce mortality when included in antimicrobial regimens for RTIs. And that includes the management of patients with resistant pathogens, because again, I think you might benefit for the anti-inflammatory or immunomodulatory aspect of these molecules, right? We do recognize today that clinical trial data is as important as it is, doesn't give us all the information that we want. Clinical trial data allows us to know that the drug works, and we know that it's safe, but it doesn't differentiate between these molecules. And as a result, when we go back and look at the pharmacokinetic and the pharmacodynamic parameters of clarithromycin and azithromycin, we see many differences. And what those differences suggest to us is that these are both good molecules, but they need to be used for the best purposes for which they're intended. The in vitro modeling, the animal modeling data, and the epidemiological data support the fact that clarithromycin is the most potent macrolide for respiratory tract infections and less likely to select for resistance, right? Azithromycin is the most potent macrolide when it comes to treating sexually transmitted infections. It has advantages if you need to use a macrolide parenterally, and it is certainly the drug of choice as an oral agent for the management of patients with Salmonella typhi. So again, they just have different purposes. So I think really in closing, we need to recognize that antibiotics are a precious resource, right? And it's us as healthcare professionals that need to recognize that and work together to try and preserve this resource, because we recognize it's not a renewable resource. And once we have completely destroyed a class of antibiotic, it's going to take a very, very long time before that antibiotic becomes useful again. And so if we don't combat antimicrobial resistance today, we're not going to have a cure tomorrow. And some of you, like myself, are beginning to get older. And as we get older, you know, our chances are increasing that someday we're going to end up in the hospital. And if that occurs, you know, I'm hoping that there will be antibiotics to treat whatever infection I might have. And I obviously, you know, very much wish that antibiotics remain viable therapeutic options for treating my children and hopefully someday, God willing, my grandchildren, right? So with that, I'm going to close and I'll stop sharing my screen, and you know, we can have a bit of a discussion. But thank you very much for your attention. I certainly appreciate it. And again, I really do wish I could join you in Pakistan. I've been there twice. I very much enjoyed my time there, and someday very much hope to get back. But for now, we have to do this long distance, and we just do our best. Okay, we're back.
Right. Thank you very much, Professor Ross, for your lovely presentation. It's always been a pleasure to hear from you. We have a lot of interesting questions and some comments also are coming in from various participants. So to move it a little forward, first I would like to have some comments from our experts that they are here with us, Professor Javed Akram, Professor Tahir Rafi, and Professor Masood Sadiq Saab. Dr. Ross has talked about some antimicrobial resistance. What is your experience like here in Pakistan related to antimicrobial resistance in your practices? So we can start with from Professor Tariq Rafiq, if you want to please share your thoughts on the antimicrobial resistance in your field of experience.
Thank you very much. Can you hear me?
Dr. Tariq Rafiq, can you hear me, sir?
Yeah, I can hear you. Thank you very much, and I'm really thankful to Professor Ross for a very extensive and a very elaborative lecture. Really, it was an eye-opener for all of us that the importance that the macrolides have and the problem that we're going to face because of the resistance which is gradually developing against these antibiotics. In Pakistan, as being an ANT consultant, we have been using a lot of macrolides in cases of upper respiratory tract and lower respiratory tract infections. This is probably one of the best antibiotics that we use and the first-line treatment that we have for our upper respiratory tract infections, both the lower and the upper respiratory tract. It has given excellent results. It is an antibiotic which we use with confidence because it has been there for so many years. The side effects and other complications are far less as compared to the newer antibiotics that we have. And this is probably one of the best antibiotics and the first choice of antibiotics that we have in this country for the upper and lower respiratory tract. The issue that has been pointed out by Dr. Ross is very, very pertinent because we are facing now this dilemma of development of resistance to these antibiotics. And I think one of the reasons for this is the misappropriate use of antibiotics by our doctors, physicians, and ourselves. And we have to be very particular in deciding when to use an antibiotic and when not to. Especially in my specialty, a number of patients with the sore throats or with sinusitis, tonsillitis do not require antibiotics. They probably have it because of viral infections or probably because of allergic rhinitis or things like that, which do not require to be given antibiotics. So that is the point where we have to concentrate and make our colleagues understand that when it is required, that we should be prescribing an antibiotic when it is not, because inappropriate or use of antibiotic when it's not required definitely will lead to development of resistance to these antibiotics. And this is one of the biggest threat that probably we are facing today. And very rightly pointed out by Dr. Ross that newer antibiotics are very scarce to be seen, very few to be coming now, and unfortunately, if they are not available very soon, then we will be in we will all be in a very dilemma what to use. Because when we see for some organisms like Pseudomonas and Proteus, which were responding very well a few years back to ciprofloxacin or other antibiotics, have now become resistant to them. So that we can point out to a number of antibiotics which have become resistant to organisms against which they were very much effective. And now we have a dilemma in chronic suppurative otitis media, which antibiotic to use. Even the third and the fourth generation antibiotics are not working on them. I don't want to see the day coming when we will not be having antibiotics for upper respiratory tract infections like these, because I personally feel that the biggest threat to mankind will not be because of nuclear war. It will be because of development of resistance to antibiotics, where we will be left with no antibiotic to treat our patients, and we'll be in a position where unfortunately we'll be just watching our patients passing, slipping from our hands. No antibiotics are there.
Absolutely correct. Absolutely
So
correct, sir. Right. So, Professor Javed Akram, how big is the burden here in Pakistan for antimicrobial resistance? Can you please share your experience here?
Thank you very much, Jandeep, and for the moderation, and thank you to GETS for arranging an excellent talk by Professor Ross Davidson. We enjoyed it, very informative, and addressing a very, very important issue of antimicrobial resistance, which is unfortunately rampant in Pakistan. We just published a study in American Journal of Infectious Diseases, and that was, of course, on salmonella from all the provinces, and about 65% resistant to to penolones, and even to macrolides. About 15% strains are resistant, what we talk of first-line drugs. So it's a very serious concern, as Professor Tariq Rafi just mentioned. Uh, mm, uh, very nicely, Professor Davidson highlighted the difference between clithro and azithro, which is extremely important also to understand. And because now I think it's more azithro somehow is in vogue, and as we just heard that in many circumstances, clithro still is better, especially if used orally. Of course, in COVID, again, people haven't used much. They are 90% of physicians, they are using azithro, and all the studies conducted are on azithro and not somehow on clithro. But I don't know, Professor Ross could probably tell us more that why it is so, why we are not giving a chance to clithro. I know there is no head-to-head trial in this situation, but still it is an important. Uh, I think the answer he himself highlighted is judicious use of antibiotic and evidence-based therapies. As Dr. Tariq Rafi just told us that we don't need a prescription in Pakistan to buy an antibiotic. And
Right, right.
antibiotics are being prescribed by aunt, uncle, and even by pharmacists, by chemists, by lay people, salesmen, and so on. So that is why the resistant patterns are here. In our ICUs, we are struggling for antibiotics use, and very commonly we are compelled to have drug holidays and to rotate the drug holidays, the antibiotic holidays, and sometimes it works. In the ICUs, most of our bugs, they are resistant to, what to talk of third generation or fourth generation cephalosporins and also other drugs. But so that is why we are compelled sometimes for 2 months, 3 months for a drug holiday, and then to bring the antibiograms back and go. So thank you so much once again.
Thank you, sir. Thank you very much, sir.
Look forward.
Thank you very much, sir, for great comments and your experience related to antimicrobial resistance. Now, well, I'll just pass on the same question to Professor Masood Siddi, because Dr. Saab is a gastroenterologist, and let's hear from him what is his perspective related to antimicrobial resistance in the field of gastroenterology. We'll take your comments. So your mic is muted. Yeah, and now it's okay.
It's okay. Can you listen? Can you hear me? Yeah. So thank you very much, Professor Ross Davidson. It was a wonderful presentation, and it covered almost all the aspects regarding macrolides, and you made your case. I've got a small little question from you, that you were talking about regional variation in resistance to macrolide in Canada. Is there any ethnic differences also? I mean, in Caucasians and other populations. Could you tell us something about that?
Yeah, very good question. My feeling would be no, that there's not. We didn't specifically look at that when we did the study, but knowing the population of Canada, we don't have any major pockets in Canada where we see one particular ethnic group over another. We tend to be very intermingled. So despite the fact that I didn't look at that, my gut feeling would be that no, we don't see any difference within certain ethnic populations.
Yeah, when we look into the different causes for development of the resistance, there are different mechanisms. I was just thinking about it. Is there genetic variations in the population or not?
There may be, but we didn't look at any host factors. Of course, we were simply looking at the organisms themselves. So my gut feeling is that there will not be any differences among ethnic populations, unless, and it wouldn't be genetic, it might boil down to one ethnic group tends to favor physicians from their own ethnic group that might use or abuse antibiotics differently than somebody else. But that, I think that would be the only reason.
Right.
Yeah, thank you very much. And as our moderator was asking my viewpoints about the resistance, I think Professor Javed Akram has said enough. And we are having resistance against azithromycin now. Thank you very much.
All right, thank you very much. I have some questions. We still have little time for questions. So there's a question is that what are the general principles or core element, general principles or just core elements for antimicrobial stewardship? So,
and again, one of my esteemed colleagues has already brought something up, which again is that it would be nice if all countries ensure that a prescription is required in order to receive an antibiotic, because as we know, many patients are going to run and buy an antibiotic simply because they have a runny nose. So that's unfortunate, but it really does go to, I mean, the overriding principle of stewardship is to not abuse the antibiotic. So it's ensuring that the right patient gets the right drug at the right time at the right dose. And of course, that also goes that patients who are very unlikely to have a bacterial infection, i.e. they have an upper respiratory tract viral infection, should not be seeing antibiotics. And that's really, certainly from a community perspective, that is the one overarching, reason that we see resistance. And of course, inside the hospital setting, there's a myriad of other ways that you can improve compliance by doing chart reviews and that sort of thing. But I think my esteemed colleague hit it on the head. You have to have a prescription to get an antibiotic.
Yeah,
and
yeah, absolutely correct.
Physicians. Yeah.
Absolutely correct. So another interesting question: what are antibiograms, and how we can implement this antibiograms in local hospital settings?
So antibiograms, we produce them in our hospital. So what the clinical microbiology lab does is we collect susceptibility data on every single bacterial pathogen that it gets processed in our lab. And at the end of the year, we publish that data for our physicians. Right? So our physicians are able to see that information, and they have an antibiogram for the most common pathogens that they're likely to see in either the hospital or the community setting against the most common drugs that they might prescribe. And that gives physicians some very good information up front to make good, informed, empiric choices for managing their patients, right? So that they'll know immediately if a given pathogen and a given antibiotic and it's 80% resistant, well, obviously they're not going to prescribe it empirically. If it's only 5% resistant, that's probably a good choice. So it really is up to the microbiology labs to produce that data and make it available for their physicians.
So do you think that these antibiograms really optimize the way we use antibiotics, and mainly we use empirically as well here in Pakistan? So do you think it's going to optimize the way we work?
Well, I think they do. I mean, again, you're still prescribing empirically, but you've got some better data at your fingertips for making a really good empiric choice. It certainly works inside hospitals, and because hospitals are different, all hospitals are different. They have different populations of patients. You need to produce antibiotics for every hospital, and in some cases, you need to produce antibiotics even inside a hospital. For example, the resistance rate of some pathogens may be very different in your intensive care units than they are on some of your other wards. Right? So I think they really do work well, and I would encourage all hospital laboratories to produce them.
All right. I have another question that's coming through another sources through WhatsApp and other channels that we are in. There's a question which is from a pediatric pulmonologist that macrolides usage in bronchiolitis. Do we have some evidence here?
We do. So there is some data on the benefits of using either azithromycin or clarithromycin as anti-inflammatory or immunomodulatory effects for severe bronchiectasis, for patients with advanced COPD, for those patients with cystic fibrosis. There's very good evidence to suggest that adding a macrolide into those patients' regimen benefits the patient. And there are published data on that.
All right. We just lost, I think, Dr. Ross here.
No, I'm here. I'm still here. Can you see me?
You are, it's being a little distorted, Dr. Ross, right now.
Okay.
I'm not able to hear you.
I can hear you fine. Yeah. Can you hear me now?
Okay. Now you can continue.
Okay.
Yes, we can hear you now. Yeah.
Okay. So what I was saying is that there is good published data for adding a macrolide in patients with chronic inflammatory infectious diseases. So cystic fibrosis, advanced bronchiectasis, and patients with very advanced COPD. So a number of published trials suggesting that macrolides are very beneficial for those patients.
But they haven't made it through the guidelines yet, right? They're not recommended. They are more experimental. This is what.
Oh, no. There are. If you look at the guidelines for the management of patients with cystic fibrosis and the management of patients with advanced COPD, those are actually in the guidelines to add a macrolide for those patients.
All right. All right. All right. I think we have passed our time, 1 minute overdue. Now, I would like to thank all my panel of experts, Professor Tariq Rafiq for joining us today, Professor Javed Akram, and Professor Khalid Shafiq, who was not able to join us, but he was definitely with us, and Professor Brigadier Masood Siddiqui to join us with us. I think we'll close this great session with, I think, with a small pledge that we have to say to ourselves related to antimicrobial stewardship, which Professor Ross very clearly mentioned, that we should look into always think about the right dose, right product, right time, right frequency, where we can, it would be our contribution to overall reduce the antimicrobial burden that we are seeing throughout in Pakistan, and which has been obviously discussed and agreed by the panel of experts that we have. So that's one pledge that I think that we should make to ourselves, that we should prescribe the products at the right time, right dose, right frequency, and right route. I think that is also there, and right indication. So thank you very much. We'll close this session. I'm very, very absolutely grateful for our entire audience to join us today. And Professor Ross for joining us from all the way into Canada. It's 6 a.m. in the morning right now.
Yes.
It's very early for him. Though the weather is absolutely very nice these days. Professor Javed Akram, Professor Tariq Rafiq, and Professor Masood Siddiq Saab to joining us. Thank you very much, audience. Stay tuned with us. We will be having another session through Webbit and other series of education programs. Thank you very much. Thank you.
Thank you very much. Appreciate it. And thank you to GETS for sponsoring this very important topic. And thank you to my colleagues for their learned comments. Very much appreciated.
Thank you very much, sir. Thank you.
Thank you.
Thank you.